Good morning or afternoon, depending on where you are, everyone. My name is Maddie Helton. I am a senior associate on the prevention team at NASTAD, and I am pleased to welcome you all to the second webinar in NASTAD's Ending the HIV Encore webinar series, Strengthening Health Department Responses to Emerging Issues, Syphilis and the Medication Shortage. This webinar is supported through PS 19-1906 funding provided by the Centers for Disease Control and Prevention's Division of HIV Prevention Bureau. We are joined today by a phenomenal panel of speakers from NCSD, JSI, and the Southern Nevada Health District. We'll have time at the end of the presentation for questions, but please feel free to send them in the chat throughout the webinar. That being said, I'm going to go ahead and stop sharing my screen and introduce our first speaker today from NCSD, Leo Parker.
Thanks, Maddie. And I will start sharing my screen. Um, if someone could just give me a heads up that you're seeing the correct screen that says the syphilis epidemic in the U.S. national landscape.
Looks good, Leo.
Thanks, Maddie. Good afternoon, everyone. Once again, my name is Leo Parker from NCSD, and I serve as the Director of Prevention. I am not Stephanie Arnold-Pang, who was originally scheduled to do today's presentation. Stephanie serves as our Senior Director of Government Relations and Programs, but since Stephanie was out, I'm happy to step in her place. Usually with anything, I like to do just a little level setting and introduce some people to NCSD. A lot of people are very familiar with NCSD, however, some are not. So this is our vision, goal, and mission. We are the National Coalition of STD Directors. We represent and serve the nation's STI professionals in the effort to address epidemic sexually transmitted infections in the United States. Our vision is a nation where all people can lead sexually healthy lives. Earlier this year, we adopted a new strategic plan that much better reflects how we work and how we serve the nation's STI professionals. And this includes a shift to a sexual health paradigm and out of a disease paradigm. Our goal is to strengthen the public health response to STIs, and our mission is to advance equitable, effective STI prevention programs and service in all communities across the country. We do this for our members. We do this as the voice of our members. So, whenever we think about our members, who exactly are our members? We represent 5,600 of the nation's STI professionals. Among them, we have our historic membership, the 65 STD directors serving every state, the territories, and 7 large cities. We also serve more than 1,400 clinic members and 1,800 DIS members. These are our 3 external facing objectives. We have a 4th focused on our own internal strength and sustainability, but these are the ones you'll see us acting to accomplish. So, as we begin to dive into today's conversation, I wanted to start it out with just some preliminary data on syphilis in the United States. In 2013, 3 states, the District of Columbia, and 1 U.S. territory had a rate of reported primary and secondary syphilis greater than or equal to 8.8 cases per 100,000 population. This increased to 42 states, DC, and 1 U.S. territory in 2022. This report includes data from years that coincide with the COVID-19 pandemic, which introduced uncertainty and difficulty in interpreting STI surveillance data. Although the male to female ratio for primary and secondary syphilis increased from 1990 to 2013, the ratio has declined in recent years due to the increasing rate of syphilis among women. During 2018 to 2020, the rate of primary and secondary syphilis among women nearly tripled. This report, this report includes data from years that also coincide with the COVID-19 pandemic. In 2022, there were a total of 3,755 cases of congenital syphilis reported among states and the District of Columbia, for a rate of 102.5 per 100,000 live births. including data from U.S. territories. There were a total of 3,761 cases of congenital syphilis reported for a rate of 102 per 100,000 births, live births. In 2013, 25 states and DC and two US territories reported one or more cases of congenital syphilis. This increased to 47 states, DC, and one US territory. It is also important to note that the American Samoa and the Commonwealth of the Northern Mariana Islands began reporting data on congenital syphilis cases in 2018. So data from that area is not available for the prior to that year. I wanted to add this slide just to kind of reiterate the slides that were before related to newborn syphilis cases. As you can see, there's a stark increase from 2012 to 2022, 10 times the increase. This slide represents some of the causes of CS cases. As you can see, inadequate treatment and no treatment causes most cases. I point this out because often we think if I can get the person tested, I can prevent a case. When in actuality, it is if I can get the person not only treated, but treated adequately, I can prevent a case. So diving more into the federal response. HHS created the Syphilis Task Force last fall. The task force has been important to promote visibility. Admiral Levine has been very passionate about the crisis and how to address it. Unfortunately, at this time, it has not resulted in additional resources to the field, but visibility is important. This visibility has sparked a lot of conversations about syphilis and congenital syphilis in key areas of our government. At the beginning of the year, FDA approved the importation of extensiline. FDA doesn't usually approve importation, and it has never been done before. A key thing to note about the use of extensiline is that we are not sure of who has utilized the drug. The drug has been hard to utilize because of cost, confusion on ordering and the use of it, and the fact that there was no big push to use the drug. Now thinking about the current shortage. According to Pfizer, Bicillin has been hard to make, and no one makes it but Pfizer. Pfizer has acquired all US manufacturers, has limited the manufacturing resources to one plant, and manufacturing is not based on epi data. Another thing to note about Bicillin is that it is expensive. One of the reasons that the 340B price is so cheap is because of the non-340B price has raised. I'm sorry. One of the reasons that 340B price is so cheap is because the non-340B price has raised faster than inflation. There is a price increase in penalty that states that if price increases more than inflation, then 340B prices has to go down. I'd also like to add that as the non-340B price increases, it prices providers out, which causes a strain on health departments to provide follow-up and treatment to patients who come in with syphilis. As many of you know, it is not our first Bicillin shortage and most likely will not be our last. During this current shortage, it was stated that there was a competitive shortage. We do not really know what competitive shortages mean, but what we do know is that penicillin is used for more than just syphilis treatment for things such as strep. So we think that this could have been part of the shortage. Currently, CDC has been working on getting an MOU with Pfizer to share data to help project differently in the future. Due to the shortage, a lot of jurisdictions have focused on patient prioritization for the use of Bicillin. The key thing to note is that as many move to alternative treatment, it creates adherence concerns, especially when you consider someone taking a medication for a month. So NCSD conducted a Bicillin shortage survey in 2013. The next couple of slides will share some key takeaways from the survey. When compared to our first Bicillin survey in mid-August, you can see an increase in the clinic struggling to get an adequate amount of Bicillin. This comes in different forms: unfilled orders, suppliers being out of stock, partial orders, delayed orders. Shortages have consequences, and we shouldn't just accept them. It has an impact on the pregnant patients. We had 13 states and one Indian Health Service region respond that they had gotten reports of a pregnant person in their jurisdiction who could not get bit. While every case noted here got treated by Bicillin, we should never accept any amount of delay as acceptable. The goal is to get everyone treated and treated quickly as possible, not to eventually get them treated. We must also recognize that it means what it means for a fetus to be exposed to syphilis. The shortage also impacts patients who are not pregnant. What we found in our first survey is that switching to doxy takes a toll on patients and on clinics. Clinics need to dedicate more time and resources to coaching patients along. Patients have challenges with adherence. The result is patients not completing treatment. And the biggest outcome, health departments expect to see the Bicillin shortage negatively impact their syphilis rates, and clinics expect the shortages to get worse. The shortage is lessening officially, according to FDA website. However, the shortage got extended throughout the end of the year. It is reported that some members do not feel impact, but are still prioritizing patients. We are not sure if the ordering system will withstand the orders coming through, which can cause further delays in clinics receiving Bicillin. So now I want to just jump to the extensive importation that I discussed earlier. This is what we know about the importation initially. In the beginning, it was limited doses. It came in a powder form in which many clinics struggled with understanding how to reconstitute the drug. And as stated earlier, the cost of extensiline is more expensive than Bicillin. In some states, Medicaid did cover the cost of extensiline, but we don't know that coverage nationally. Some health departments may not have contracts with the distributor, and the process of creating a contract can be burdensome, which also led to challenges with retrieving extensiline. As of today, we know that the shortage is lessening. However, some states are still not receiving full orders, which leads to the prioritization of those who get Bicillin and who will get doxy. We don't know the answer, but we most think that we don't know the answer, but we must think about the impact of doxy use down the road. Meaning, will we see an increase in cases because of misuse? In recent news, Mark Cuban Cost Drug Plus Company announced FDA approval to import litinacin. Litinacin is a Portuguese manufactured version of Bicillin, and the cost of litinacin is $15 a dose, which is a fraction of the cost of Bicillin. Currently, we do not know if people have begun using this, but we will keep close watch. This did just come out this past July, so it is still relatively new. And as I close, I just want to reshare this particular slide just to reiterate the importance of adequate treatment. Take note once again that over 50% of cases was due to inadequate treatment or no treatment at all. I know that Maddie said we will have time at the end for questions, but I do want to just post these questions just to kind of get people's minds thinking whenever we think about Bicillin shortages, administration, and what is to come. Just a couple of things just to kind of keep in mind for down the road. And then lastly, as I mentioned, Stephanie Arnold Payne is our director of policy who leads our Bicillin work. This is her contact information. And of course, this is my contact information. And I'll stop sharing now, Maddie.
Thank you so much, Leo. I will kick it over to our next presenter, colleague from JSI, Devon Brown.
Thanks so much, Maddie. I'm going to go ahead and share and hope I do this correctly. All right. I think you all are seeing what you should be seeing. Maddie, could you just confirm for me?
Looks good.
Perfect. Appreciate that. All right. Good afternoon, good morning, everybody, depending on where you are. My name is Devon Brown. I am a senior associate at JSI, and I'm a TA coordinator on our Integrated HIV/AIDS Planning Technical Assistance Center, or IHAP-TAC. I am really delighted to have the chance to contribute to this webinar today and to talk a bit about how effective integrated planning and related activities support a responsive system of care, which we know is really critical during public health crises. So just as Leo did, before I dive into integrated planning, I just wanted to give a quick overview of IHAP-TAC in case anybody out there isn't familiar with us. So since its beginning in 2016, IHAP-TAC has been funded by HRSA HIV/AIDS Bureau, or HRSA-HAB, to provide support to Ryan White HIV/AIDS Program Part A and Part B recipients, CDC Division of HIV, Prevention Health Department recipients, and their respective HIV planning bodies. So at IHAP-TAC, we conduct national and individualized training and technical assistance, or TA, and facilitate peer-to-peer learning. And we really focus on all stages of integrated planning, including the development, implementation, and monitoring of the integrated HIV prevention and care plan, which I will talk a bit more about in just a minute. You can find more information and resources from IHAP-TAC on our Target HIV website, which is targethiv.org/IHAP. And I will have that website toward the end of my presentation today. All right, so some or perhaps most of you are familiar with the Integrated HIV Prevention and Care Plan that I will refer to as the Integrated Plan moving forward. But just in case you're not, the Integrated Plan is a document that HRSA and CDC require from their Ryan White HIV/AIDS Program and CDC prevention funded recipients every 5 years, and it details how a jurisdiction will establish and maintain coordinated and effective HIV prevention and care systems. So while the contents of the integrated plan is directed by HRSA and CDC guidance, the approach to integration is determined by each jurisdiction. So the image on this slide that you see here illustrates the 5 stages of the integrated planning cycle, each of which is driven by jurisdictional needs and priorities. Integration does not look the same across jurisdictions and can happen in different ways, including across HIV and other infectious diseases. The integrated plan is intended to be an actionable, living document that is reflective of community needs and priorities. And the development and implementation of a representative and realistic integrated plan requires strong community networks and routine communication, and that is really the theme of my section of today's webinar. So why is integrated planning important? The integrated planning process requires communication within jurisdictions to ensure the accurate identification of need, inclusion of stakeholders, and development of an efficient and comprehensive approach to HIV prevention and care coordination. The process represents a collective effort among a variety of partners, including people with HIV, communities experiencing increased risk of HIV and related comorbidities, service delivery providers, state, local, and tribal authorities, and other community members to prioritize and coordinate thoughtful HIV prevention and care approaches. Jurisdictions document the data and strategies identified through the planning process in their integrated HIV prevention care plans, which then guides how that jurisdiction will continue to strengthen their systems of care. Successful integrated planning can result in what you see outlined on the slide here, ultimately supporting a more coordinated, creative, and efficient approach to providing HIV prevention and care services. Strong planning is imperative for effective local and state decision-making to develop or support holistic systems of prevention and care that are responsive to the needs of people with HIV and those who could most benefit from prevention services. I said it earlier, you're going to hear me say it again. Community engagement is an essential component for planning comprehensive, effective HIV prevention and care programs in the US. So now, what do we actually mean when we talk about integrated planning activities? What does this look like? So as you can see here, integration can take place across several domains that include planning groups, planning activities, physical integration, recipient staff, and procurement. In addition to occurring across different domains, integration can also occur across a spectrum within each domain, which ranges from no integration at all to full, complete integration. On the next few slides, we'll look a bit more closely at how integration can happen within different domains and then across the spectrum, just to give some more concrete examples of what this really means and how this can really look. So here are some examples of how integration can occur within an organizational structure. And the domains you see listed here include communication, data sharing, and/or structure and leadership. And the point we really want to emphasize here is that integration does not look the same for everybody. Again, not a one-size-fits-all approach. And this slide, along with the next couple slides, we hope really exemplify that. So this slide describes how integration can occur within the procurement domain. And since I think it may be hard for folks to read the fine print of the braided funding description at the bottom of the slide, I'm going to go ahead and just read it out loud. So this process is defined as a process in which stakeholders coordinate funding from individual sources, with each individual funding source keeping its specific identity. And that braided funding is a part of how full integration of procurement can look. And finally, here's some ways in which integration can occur within the planning bucket. So it can take place within planning body structures, decision-making or priority setting processes, resource allocation, and/or the special initiatives planning process. So just as an example, Ryan White HIV/AIDS program Part A and Part B planning bodies or planning councils and CDC funded HIV prevention planning groups conduct complementary planning activities and offer a promising opportunity for integration. So while not all jurisdictions will be able to merge existing planning bodies into a single integrated HIV prevention and care planning body, all jurisdictions can determine what structure and level of integration works for them to accomplish the goals of integrated planning. All right, so integrated planning supports jurisdictions in their efforts to meet the National HIV/AIDS Strategy, or NHAS, goals and complements activities related to state or local ending the HIV epidemic, or EHE plans. Across all national and local initiatives, like the Integrated HIV Prevention and Care Plans, EHE, Getting to Zero, jurisdictions are encouraged to meaningfully engage community and essential partners, orient toward achieving health equity and reducing disparities, focus on priority populations to ensure those with the greatest need are being prioritized, and implement status-neutral approaches to strengthening equitable access to services and related health outcomes. And we all know that HIV prevention and care efforts do not and cannot take place in a vacuum. Successful planning must consider the full landscape of funding, of partnerships, and any systemic gaps that are existing. As we saw in an earlier slide, one of the major stages of integrated planning is to organize and prepare, which includes identifying a jurisdiction's available resources. It also is an opportunity to highlight potential partnerships. Effective integrated planning incorporates activities that respond to biomedical and social determinants of health needs and really benefit from a syndemic lens. And planning activities should reflect and prioritize local needs, which can only be done through meaningful engagement of communities and community partners. Relationship building and maintenance is crucial for sustaining a responsive system of care. People seeking HIV prevention and care services simultaneously need other services, and often the inability to meet needs, maybe not directly related to HIV, like housing, employment, behavioral health care, can inhibit their ability to then access their HIV-related services. Ideally, integrated planning activities nurture the creation of a status-neutral or whole-person partnership network that is reflective of and responsive to local needs. All right, so you saw this image earlier. I'm bringing it back one more time. So all of us here know that the only way to know what communities need is by talking with the people in these communities. Routine, genuine communication is central to successful integrated planning because that's how we foster trust, demonstrate commitment, and ensure that related activities are relevant. You can see here that community engagement is at the core of the planning cycle and is something that we emphasize in every single stage. Further, as touched on in an earlier slide showing organizational integration, communication and data sharing across organizations or divisions can foster a more nimble and responsive network. We know that working in silos slows down processes and creates unnecessary gaps into which essential information and people, not literally, but people can fall. Just as we do in planning groups of all kinds, creating routine opportunities for community partners to convene can strengthen ties and position a jurisdiction to be ready to respond when an urgent need arises. So I want to end my brief section with a question for you all to consider. Where do you see opportunities for stronger network ties in your jurisdiction? Where are the relationship or network gaps? To create a more responsive and holistic system of care, who do you think should be talking but isn't? All right, so just to wrap up, if you are new to integrated planning or if you would like a refresher, we encourage you to start with our Introduction to HIV Prevention and Care Planning, which is a self-paced online course that provides a detailed overview of integrated planning. It goes into a lot more information and description than I covered earlier in this section. So we definitely encourage you to go check that out. And if you just really aren't sure where to start or what you need, you can visit our website to subscribe to our mailing list, review the resources and tools we have available, or request tailored technical assistance. And you can access all of this information via our website on targethiv.org, which is on the slide here. And that concludes my section for today. So thank you so much for this opportunity. And I'm thrilled to turn the mic over to the Southern Nevada Health District.
Thank you so much, Devon. And much like you said, I am happy to introduce our next speaker from the Southern Nevada Health District, Dr. Rosanne Sugay.
Hello, thank you so much for having me today. And let me see, thanks, Maddie. I've been having computer issues, so Maddie's been kind enough to share my slides. But again, I'm Rosanne Sugay. I'm the medical epidemiologist at Southern Nevada Health District. For most people, that would mean Las Vegas. And I'm really going to try to talk about our community response to the Bicillin shortage and sort of puts a real-time example of how some of this collaborative process happens. Lourdes Yapoko is our Director of Public Health and Preventive Care. She was supposed to help present with me today, but is out sick and unable to attend. Next slide, please. So just as a brief background about Clark County, Nevada, which most of you will probably be more familiar with Las Vegas, we have a population of about 2.3 million residents in a state with about 3.5 million people. So predominantly most of the residents in Nevada are located in Clark County, which is where Las Vegas is. And we get 42 million visitors annually. So on top of that, we sometimes tell our residents that what stays in Vegas after a weekend of a big party, unfortunately, sometimes are HIV and STIs. This is an age distribution in Clark County. You can see race, ethnicity. We're sort of a majority minority state where 40% are white. And again, a majority of the minority populations are a little bit over majority when you look at it total. So 32% Hispanic, 13% Black, 11% Asian, 5% mixed race, and 1% American Indian. In terms of income, you see kind of the median household income and industry. Of course, tourism accounts for about 10 billion of our funding, also provides jobs for a whole lot of people in Nevada. Next slide. So primary and secondary syphilis rates in Clark County versus Nevada versus the US in 2022. You can see that Clark County, our rates are about 30.6, which is higher than Nevada's rates, higher than the US rates. We've marked South Dakota and Vermont, which is the highest and the lowest rates of primary and secondary syphilis. Luckily, our rankings have actually improved somewhat. There was a time a few years ago where we were number 1 in the US for primary and secondary syphilis. We're now at number 5. Next slide, please. In terms of congenital syphilis rates, again, Clark County rates versus the whole state versus the US and the highest and lowest states in the country. You can see that Clark County, again, has rates that are higher for congenital syphilis than the US. And also good news, our congenital syphilis rankings improved. There was a time a few years ago where we were also number 1 or 2 for congenital syphilis, and now we're number 9, at least in 2022. Next slide, please. All of this to say that the community is fairly well versed in dealing with syphilis, primary, secondary syphilis, and congenital syphilis, and that helped sort of with our early response to the Bicillin shortage. So just let me walk you through the story of what's going on in Southern Nevada. I mean, as the previous speaker had mentioned, when we talk about syndemic approaches and braiding funds and ensuring community engagement, I'm a glass half full sort of person. So I'm going to couch this in the fact that it's a good thing that we have to braid our resources because they're limited. But because of that, the HIV integrated plan, the people in the community who are engaged in HIV prevention and treatment are also sort of the same group that works in STI prevention. And when we talk about our early response to the Bicillin shortage at the health districts internally, the minute we heard about it, we met with our chief medical officer at that time, as well as the prescribing providers, the pharmacists, and the nurse leadership within the district. Just as a little bit of background, at that time that this was all happening, I was actually still employed at one of the big university medical centers here in Las Vegas, and I wasn't working at the health district, but we had a good enough relationship that, you know, within a couple of days of hearing about the Bicillin shortage, Lourdes, who's not here with me today, and I were both on the phone talking about how our organizations were dealing with it and what to do for the community or how we were going to approach it if the Bicillin shortage continued. So we used sort of the CDC guidance to prioritize the use of our Bicillin, and sort of came up with a grid where we would use it for pregnant people with syphilis, patients with contraindications to doxycycline, partners of pregnant people, and people with an HIV diagnosis. And then depending on how much Bicillin we had in the community, we trimmed down that list based on need. Next slide, please. And so when we got the news of the extended Bicillin shortage, by that time I was already working at the health department. So we got our internal stakeholders at the health department to all come together and sort of discuss what options we had. And what we did was we reached out to our community network. And as I said, it's sort of the same group of people that are involved with our HIV integrated plan and sort of the coalitions we have around HIV and STI prevention in the community. And we reached out to all the main clinics in town that we knew typically had access to Bicillin and could take care of syphilis. And that's a list of the external stakeholders we had. We got them all on a call. And basically what we did was we explained the Bicillin shortage. We all encouraged them to sort of come up with their own grid of how they were going to be using their Bicillin. And what we all came together to decide to do as a group was to actually have sort of a community inventory, right? We figured out how much Bicillin each facility had in their capacity to take in patients who might need a treatment if they were at a clinic that was running low on Bicillin. So what did that look like in real time? Next slide, please. We came up with a communication plan for cross referrals and inventory. So all partners would provided a contact person for a warm handoff, provided information about services offered, what times their clinics were open, their capacity to take in patients same day. They provided information in the referral process and documents needed for their clinic, if there were any insurance barriers or the like. And we met regularly. So the cadence was weekly at the start. And what we did was we basically came out with an email that would get pushed out to providers at the end of the week, where they would tell us their inventory. And every Monday, somebody at the health department would then send it out to all the members of the group in terms of how much Bicillin each clinic had and their capacity if anybody needed to transfer a patient there for treatment. We did give special consideration for ethical principles in resource allocation in terms of just, again, trying to stratify patients depending on our existing inventory of Bicillin in the community. And as I said, we had the weekly automated email to request current inventory from different locations that we sent out and updated. Next slide, please. And part of the reason that this wasn't us reinventing the wheel was that we already had the framework in place because we had case management and disease investigators prior to that. So we did have nurse case managers for a congenital syphilis program that was already in place. And so that was another layer of coordination that was already there, and they were able to successfully link patients to care with community partners that had available doses, and again, often with same-day referrals. We also have a home administered treatment for syphilis program for pregnant persons who are unable to make it into their clinical home for whatever reason, where our nurse case managers are actually able to meet them at their homes to give them their Bicillin treatment. And then on the surveillance side, we do have our disease and intervention and investigation specialists who work closely with our case managers and community partners on referrals to care. And our disease investigators were the ones who spearheaded maintaining the document for all partners in terms of updating their Bicillin inventory. Next slide, please. And so through all that community planning and the framework we already had built in place because of the work we do on HIV prevention and HIV care, the collaboration was pretty easy to stand up and enabled us to do a coordinated response. There was minimal impact on timing of treatments. Luckily, we never had an issue where we did not have Bicillin. Pregnant persons received timely and complete treatment. And this sort of improved giving the Bicillin injections in patients' home also improved treatment time. And the increased collaboration among community partners beyond syphilis treatment really helped with this response, where we had just started to make stronger connections and partnerships and a platform to share best practices in real time. And next slide. I think that's it. I don't know if you have any other questions for us about what we did here in Southern Nevada.
Wonderful. Thank you so much, Dr. Sugay. Thank you so much to all of our speakers today. I know that a couple of our speakers posed some questions earlier, so as we open the floor to questions from the audience, please also feel free to answer any of the questions posed earlier from our speakers. All right, well, hearing no questions and seeing no questions in the chat, we can leave the floor open for that for another minute. But in the meantime, I will go ahead and put up the contact information of all of our speakers from the webinar.
So I have a question, Maddie. Has anybody used Lentocillin? We luckily haven't had to use it in Southern Nevada, but I'm just curious to see if anybody's had any experience with it.
Looks like not in New Hampshire. All right, I guess not. Or, well, not in Michigan either. All right, well, if there are no other questions, then I would like to thank everyone for attending this webinar today. The slides and recording will be made available on NASTAD's website, and we will notify everyone via email when that is up. Also, I would like to thank our speakers from JSI and CSD and Southern Nevada Health District. Thank you so much, everyone, and have a great rest of your day.